Yeah, so we're Health Frontiers Canada. This is the Resolution Refined podcast. We came together a year and a half ago to talk about issues that we've personally experienced and our family members have experienced in the healthcare system. And currently, our projects are centered around the Resolution Refined podcast, the websites, and our guides to care, and also our project with UBC Housing to help put AEDs and naloxone kits in the first year residences. And we hope to continue these projects to hopefully raise awareness and make systemic change. And to introduce ourselves, my name is Adi Swaro. I am the VP, and Rade Sani, who's president, and then Nick, who is VP External.
We have the absolute pleasure of being joined by Dr. Sanjeev Gandhi today, who practiced as the head of pediatric cardiothoracic surgery at BC Children's from 2010 to 2022, and is now working to improve access to care across Canada.
Okay, so we'll get started with the interview now. Dr. Gandhi, what is your perspective on the state of Canadian healthcare right now, from the perspective of a doctor and someone who's worked in Canadian healthcare?
Well, first of all, thanks for having me, and thank you for doing this. I don't think it's a surprise to any of you and most people that follow this that the current healthcare system is really just broken. It's the way I see it, it's handcuffed by this suffocating grip of bureaucracy and politics, and the people trying to deliver healthcare, the healthcare providers, are buried under this mountain of bureaucratic obstacles that really impede their ability to provide the best care possible to patients. And politics has taken over almost every crevice of the healthcare system. And now I think we have a situation where decisions are driven more by personal and political gain, partisan agendas, than by the best interests of the patients. And it's the patients who ultimately suffer the consequences of those decisions. When it comes to their health, Canadians just want to be able to access the healthcare system, do it quickly, and they want to know that the system will do whatever possible to prevent them from getting sick or to make them better if they're sick. And right now, that's sadly not a reality.
Thank you for that. It sounds like you have been devoting yourself to working to improve the system. What steps do you think that we need to be taking as a society to move to a better system and improve the broken system that currently exists?
Well, I mean, there's a lot of things that need to be done that aren't being done. And there's a lot of concentration on things that are not necessarily giving us the biggest bang for the buck. But the solutions start with access, first of all. I mean, Canadian healthcare should be universal, equitable, and timely. The patient should just get the care they need when they need it. That's the goal, right? And that starts with access to primary care. I'm the son of two family docs, and even though I chose a specialty that's super specialized, I understand the importance of primary care. Primary care really is it's the heart of medicine. It's the heart of prevention, education, mitigation of disease. And what politicians obviously often don't recognize is that the number one key to a successful healthcare system is to just keep people healthy in the first place. Preventing disease isn't just good medicine, it's good economics, is what they tend to latch onto. And healthier people are not only easier to care for than sick people, they're cheaper to care for than sick people. So primary care is the front line of healthcare, and everything else is really just illness care. And that's what we have now. We have an illness care system, not a healthcare system. The family doctor problem is not new. My dad died in 2014. He practiced in a rural town in Nova Scotia. And even then, the exodus of one doctor from the system who had been there for 40 something years created problems. So it's not a new problem. There have been struggles with primary care access in Canada for years. And the family doctor problem, despite what people want to tell you, it's not a numbers problem. It's a practice problem. So in 2023, the last time the numbers were released, there were over 7,000 licensed family doctors in British Columbia. So even with a patient panel that's less than that suggested by the Ministry of Health as being complete, I think their number is 1,250 per doc. 7,000 is more than enough family docs to suffice for the population of BC, even considering significant population growth, right? Like if you take 1,000 patients per doc, 7,000 times 1,000, 7 million. Right now, the population of British Columbia is a little over 5 million. But the issue is that only a fraction of those 7,000 actually practice longitudinal family care. They practice family medicine like we know it. It's much more user friendly, profitable to take your talents elsewhere, doing hospitalist work, emergency room shifts, operating room assisting in non-university centers, or engage in frankly low stress, highly compensated work like cosmetics. So primary care isn't working the way it's structured right now, and it needs to be restructured. It needs to be delivered by multidisciplinary teams, community health centers with proper government supported infrastructure and team-based complete care. I'm not talking about just docs. They need to be NPs, physicians assistants, physios, social workers, mental health professionals, so that these centers are like one-stop shopping to make care accessible, timely, and coordinated. And so the attractiveness of primary care has to be elevated, its prominence has to be elevated. And primary care teams ultimately have the power to completely control the delivery of healthcare. But they have to be empowered to do so. And it's only by solving the primary care problem, not the numbers problem, but the delivery problem, that we're going to intervene on these issues.
I see. So I guess what I'm hearing is that it's not just about more funding or more physicians. It's about recreating a system that allows primary care to take over before there is a situation where we run into massive wait times when it comes to surgical wait times and stuff like that.
Yeah, everything flows downhill from that, right? Like the longer it takes to diagnose your breast cancer, the more advanced it's going to be, which impacts the system down the line. It causes a domino effect. It's definitely not solely a money issue.
Mm-hmm. Yeah. You have a question?
Yeah, on the note of primary care, one of the reasons for me to get involved with HFC at least was I had a scenario where like I used to get sick quite often in terms of I'd get infections, and when I moved to UBC, we have this student health services service, and so I would go in, and the first appointments that they would give for something like an infection was, I think, 3 or 4 months away. And for me, that really frustrated me because obviously, first of all, like I wasn't going to be sick in 4 months if I had an infection right now. And the issues I was facing right now with my stress was around exams and my school. So it also exacerbated the anxiety that's associated with that. And like it got to a point where going back to Alberta to where my parents are, who are also both family docs, was much easier to see a primary care physician. And for me, those are the reasons to get involved in this. And I guess my question is, and I know you list this on your website, on your My Statements page, if you have stories, or if you could maybe expand on your story that you listed there about I think it was a baby that needed a transplant and you guys had to go to Alberta instead as well. Expand on that, or talk about any other stories that motivated you to get into politics more.
Well, I mean, that story is a very specific story, but I I worked in the States for a long time, even though I'm from Canada, and came back in 2010. And Canadian healthcare wasn't nearly as hamstrung in 2010 as it is now. And it certainly was a lot better when I left in 1993. And so I've seen Canadian healthcare work. Like I know it can work. and I've seen the other side of the coin south of the border too. But we got to change what we're doing. We can't fight the system. We have to make it about fighting illness.
Mhm.
Canadian healthcare has been excellent in the past, and it can continue to be so in the future. And that's what frustrates me, that we're not getting there. We can provide universal health coverage for essential medical services to everyone at a reasonable administrative cost. But in this era of super specialization and technology, speaking as a pediatric heart surgeon, we can't lose sight of the importance of primary care, preventative health care, and management of chronic disease. I mean, Canadians used to have phenomenal outcome metrics like infant mortality rates, immunization rates, survival rates for cancer, cardiac disease, life expectancy. All that stuff was excellent in Canada. It supported the assertion that overall the population was healthy, which meant that the Canadian healthcare system worked well. Those are really the metrics of a healthcare system, not stuff that politicians like to measure, which is, how many contracts have we negotiated? How many MRIs do we get done? Like that doesn't tell you anything about a healthcare system. How many procedures are getting done? Like, speaking as a surgeon, the number of operations a healthcare system is doing is not in any way, shape, or form a metric of how well the healthcare system is operating in terms of how we're keeping people healthy. There's a book called Overtreated that's about the American healthcare system, and it goes into just that. Just because you're doing more stuff on people doesn't mean you're making them healthier. In fact, it might be an inverse relationship. But we used to have metrics that showed that the Canadian healthcare system worked well, and frankly, the Canadian healthcare system should evoke a sense of pride. And it's always been the most cherished social system in Canada. But we need to have people that have the courage to change what needs to be changed. And really, healthcare reform in Canada has been lacking a vision. It's been void of real reform that's required to get Medicare back on track. What's been missing from these so-called leaders of ours is some true leadership, like a firm commitment that every Canadian will have ready access to a primary health care provider. And all the public is currently getting out of the current approach is a formulaic growth in spending. It's the same old stuff, like spend more money without producing outcome metrics that match the spending or results that one should get with spending the money.
So if I'm understanding that correctly, it's not a matter of funding, it's a matter of like restructuring the system, like you said earlier.
It is, and it's like, it's not about money, it's about efficiency and cost effectiveness. So I mean, obviously the former drives the latter, but improvements in the system can be accomplished by changing things that improve efficiency, which improve care, and actually consequently decrease rather than increase cost. The more efficient the system is, the less costly it is. And there are lots of examples of creative approaches to care which increase efficiency and decrease cost that have not just gone unsupported, but have actually been discouraged by government, specifically in British Columbia. And even the administrative system is anything but efficient, right? In BC alone, billions in cost, like billions with a B in cost, have been added to the healthcare system over the past couple of decades, but most of it's administrative and almost none of it's attached to any degree of accountability. So, like, you need major surgery to cut out the redundancies and the massive waste in healthcare, which is replete with middle managers, vice presidents, directors. They soak up resources, they have no accountability and no responsibility for outcomes. Like a year ago, Ottawa injected all this money into the system, $196 billion over the next decade. And that was the headline they were looking for. Like, okay, we're going to increase funding. But when you look at the package, there was very limited targeting. Like, there was some money for mental health and substance use, home care wage increases for personal support workers and long-term care, but there were no real metrics, like real ones. People want results and metrics. They want to know, how long it's going to take to see a doctor, like you said, how long it's going to take to get an operation, how long it's going to take for me to be seen in the emergency room. And to measure those outcomes is the only way to assess the improvement. There's a saying in medicine, like, if you don't want to know that the patient has a fever, don't take their temperature, right? So effective healthcare involves monitoring and evaluating outcomes to assess the impact of interventions and to identify areas of improvement. Outcomes aren't, again, they're not number of operations, number of diagnostic tests, all that kind of stuff. It's about people, and people care about transparent metrics.
Okay, so given the growing population, kind of in combination to the declining access to family doctors, how does Canada build a system that is first and foremost resilient in the face of growing demand?
Can you say that again?
So given the growing population in combination to the declining access to family doctors, how does Canada build a system that is resilient in the face of this growing demand?
Yeah, well, I think it's all of the stuff that I said, like it's
Yeah.
improving efficiency, it's restructuring the way that primary care is delivered in terms of community health centers, and not having doctors be business people, right? Like, doctors go into medicine, or people go into medicine to be doctors and take care of patients. They don't go in there to run a small business. And that's what we ask physicians to do, is to run small businesses in this country. And that's not a system that's sustainable anymore. It should be treated like we treat schools. We don't ask teachers to hire the janitors and buy the paper clips and clean the floors and, administrate the schedules. Like, we ask teachers to teach our kids, and we should ask doctors to take care of our patients. And by adopting a team-based care model, that will build the resiliency necessary to absorb crises like the COVID-19 pandemic, which the thought of it alone crippled us.
I just wanted to follow up on a couple of points. So
Yeah.
I think it was interesting you mentioned that before it was good. And I wanted to ask, like, if you know, like, specifically what parts of it have changed and what causes those change. Like, you mentioned a few, like, metrics, bureaucracy. Is it a combination of those changes that have changed the system overall now? And if so, what initiated those?
Yeah, I mean, I think it's a combination of all of that stuff. In addition, part of it is sort of the evolution of healthcare. I mean, healthcare has become a lot more complex. When I was a general surgery resident and kids showed up to the ER with belly pain, and you were worried about appendicitis, you examined their belly and you made the decision. Like, that was it. There was no, I'm dating myself, but there was no ultrasound. There was no easy accessibility to CT scan. And I trained in the United States. So, like, you couldn't just send a kid for a CT scan. That wasn't a thing for diagnosing appendicitis. You took their history, you did a physical exam, and then you decided, do they go to the OR or not? And that was that. And now it's ultrasounds and CAT scans, and there's lots of technology involved. And I'm not saying that that's necessarily a bad thing, but it's complicated things quite a bit. The population is obviously aged too, and there's more disease in the population in general. And I think the delivery of healthcare has become more complex because of it, but we haven't adapted to that. Like, there's a lot of things, especially in the Canadian system, that can be taken care of, not the complex stuff, but the less complex stuff that can be taken care of in settings that are not in a hospital. But we don't have the structure to be able to deal with that in this system. Like, for example, my daughter, when she was, I don't know, 5 or 6 or something, had a UTI. We took her to the emergency room. It was in the States. And they gave her a shot of some antibiotic, stuck an IV in her, and sent her home. She needed IV antibiotics for 7 days, but she didn't spend a minute outside of the emergency room in a hospital. Like, there was home care set up, and nurse came and gave her the antibiotics twice a day, and that was that. And that was a whole lot cheaper than spending 7 days in a hospital. But if I was to try to get outpatient intravenous drug therapy in Vancouver for a child, it's impossible to do so. We don't have that structure available. There are more systems available in the adult world, but they're still limited. That's just one small example. But we haven't kept up with that sort of thing to be able to adapt the system to what's necessary in 2024.
I see. Something that really stood out to me was the fact that, you've practiced for 17 years in the States, you've experienced that system, and you've been here for so long as well and trained here. When we look at the American system, obviously it has its pitfalls. What can we learn from the American system, and then what can we avoid based on the things that are going wrong over there?
Well, I mean, the American system, I wouldn't want to ever go on record and saying the American system is something that we should model, because it's not. I mean, first of all, the objectives of American healthcare and Canadian healthcare, strange as it may seem, are quite different. So the objectives of American healthcare are, number one, to take care of the individual patients. Taking care of society as a whole is not necessarily an objective of the American healthcare system. Whereas in Canada, the goal should be to take care of society, right? It should be universal healthcare. Healthcare is a right, not a privilege. In the United States, it's clearly a privilege. It should be a right in Canada. And secondly, the goal in the United States is to make money. And that's the goal in Canada, is to save money. They're diametrically opposite, right? So when I was in the States, and the ICU was 97% full, the administrators would be pissed off because where are the other 3%? Like, we need to always have it 100% full. Whereas here, when it's 97% empty, everybody's rejoicing, which is the way it should be, because that means we're keeping people out of the intensive care unit, we're keeping them healthy. So things like prevention of severe illness or trauma, getting people to wear their helmets when they ride their bicycles or ski down a mountain or whatever, are important aspects of healthcare. Public health is an important aspect of healthcare. So the two systems have different goals, but that's not to say that everything in the US system is negative. It's not. And the things that are beneficial as a result of the bad system, which is to make money, is that it's more efficient. Because people driving progress are the insurance companies. Now, the insurance companies have a lot of things that I could say negative about them, but they're going to force short hospital lengths of stay. That doesn't mean you have to acquiesce to that, but there are times when that's appropriate. They're going to force certain practices to increase reimbursement. Like, for example, I don't know if this is still the case, but when you were practicing adult cardiac surgery in the United States and you discharged somebody after a coronary bypass operation, you had to have at least document that you had a discussion with them about the applicability of statins to lower cholesterol. Obviously a high risk factor for recurrent coronary artery disease or coronary artery disease in general. And if you didn't document that, the funding you got for the cabbage wasn't as much as if you documented that it happened, right? Like, that's one tiny example, but those sorts of efficiencies are forced in the American system. Length of stay is a forced efficiency in the American system, or shortening length of stay. At-home care is a forced efficiency in the American system when necessary. And sometimes it's to an extreme that's unnecessary, but a lot of those things don't exist in Canada because there is no competition here, and it's a publicly driven system.
Yeah, if I may follow up on that, thanks for that comparison, first of all. Earlier you described a system that is similar to how we run schools. To me, that reminds me of the UK-based NHS system. And is that something that perhaps you can also compare to the Canadian system?
Well, yeah. So I'm not familiar with exactly what happens in the NHS right now. There's a lot of problems with the NHS right now, but one of the things that was good about the NHS, at least from my perspective, was the capitation system as far as primary care goes. So you weren't getting compensated as a doctor for a fee for service sort of thing. You were getting compensated for the panel of patients that you cared for. And so it incentivized you to take as good of possible care of that panel of patients as you could. Like, it was in your vested interest to keep them healthy, right? In the American system, it's not in anyone's financial interest to keep anyone healthy. Like, as a surgeon, you get paid for doing operations, which is what I hated about that system. Now, I didn't, I was salaried, but so it didn't matter if I did 1 operation or 20 operations, but it did matter at the end of the day, because even though I was salaried, they measured these things called RVUs, relative value units, and bonuses and things like that were all based on productivity, and productivity had to do with clinic productivity and surgical productivity. So it did matter a little bit at the end of the day, even for a salaried person. And for a non-salaried person who's getting compensated based on the actual operation they do, it's in your vested interest to operate if you're a surgeon, or to do if you're a gastroenterologist, or to investigate if you're whatever, right? And that's why if you drive through any major American city, like, there's massive hospitals on every block, like, they're all over the place, right? It's the biggest industry in America is healthcare. And in the Canadian system, in the fee-for-service system, it also doesn't incentivize you to take good. I don't want to say that people don't take good care of patients, but there's no financial incentive to keep people healthy from that perspective. In the capitation system, there is, because the less you keep them healthy, the more you're going to have to work, and the more you're going to have to work isn't going to correspond to the more that you get paid. So there are benefits to that system. Now, the amount that doctors get paid in the NHS has not kept up with the times, which is why British Columbia is trying to poach docs from the UK right now. But there are advantages to all of those things. And I think some combination of the capitation system and a salary system in Canada for a lot of doctors would make sense.
I see. Yeah. Do you have a question?
No, I have.
Okay, I'll just continue then. Thank you for that. It sounds like those metrics go where the incentives go with the money.
Yeah.
I'm wondering, sort of diving deeper into that, what is, like, within the next year or next 5 years, what are tangible actions that you hope to take to improve the state of the system as it currently stands?
Well, that's a great question. I don't know the answer to that, because, as you probably read about, like, my life in politics doesn't exist anymore. So, if I can affect change outside of politics, I'll try to do it. And I'm investigating ways to try to do that right now, but I'm still sort of in the transition phase. But I think, in general, if we could figure out a way to dissociate politics from healthcare, it would go a long way. Like, if you ask me, to take care of Canadian healthcare like Canadian healthcare with my patient, right? I'd tell you, first of all, we don't need any more testing to determine the diagnosis. Like, we know the diagnosis. More testing, just a waste of time and money. And right now we have a lot of team members, politicians, that don't have the training or expertise to cure the ailments of our patient, the Canadian healthcare system. And the direct involvement of government really needs to be diminished, if not eliminated, because governments have just demonstrated a complete ineptitude in solving the healthcare crisis in Canada. It makes for great political platforms and, you know, sound bites, but meaningful action has been glaringly absent. And honestly, this won't be popular if people hear this, but professional organizations like the Canadian Medical Association, they've had limited impact, right? They have plenty of spokespeople who demand this and proclaim that. But when you really look at their list of tangible accomplishments, it's been few and far between. Those professional organizations are about advocating for CMA for physicians, Docs of BC for physicians. Not that there's anything wrong with that, but those organizations have not demonstrated the ability to impact changes in healthcare. What healthcare needs, again, as my patient, is like major surgery. Like, I'd take it to the operating room, I'd surround it with the best team of nurses, perfusionists, anesthesiologists, pick the best assistants, and open it up with a knife and cut out the bad parts, like, again, as a surgeon, like including layers and layers of unnecessary and obstructive administration, and sew back the good parts in a way that, you know, the circulation is functional at the end of the case. And so I think healthcare professionals need to drive this boat. Trying to separate politics from healthcare is the difficult part, again, because doctors don't go in to medicine to administrate healthcare, but the administrators of healthcare currently don't know much about it. So it's a difficult proposition, but I think the more people of my generation that are no longer have a scalpel in their hands or aren't taking care of patients anymore, that can listen to people of your generation and know what we need to do and try to affect the change, that's sort of the only way that we're going to make an impact.
Awesome. I love that analogy of treating healthcare as your patient, treating the system itself. Thank you so much for talking to us about that part of Canadian healthcare.
Sure.
If I may, the two of us are planning on working in healthcare just as you did for years. And I'd love to ask a few questions about your experience there and how we can be better stewards of healthcare. Starting with just sort of, I'm curious, what was it about surgery that drew you in? And then specifically, what was it about pediatric cardiothoracic that you found interesting?
Well, I never planned to go into surgery, to be honest with you. I assumed I'd be a family doc like my parents. But then, due to some life circumstances, I grew up in Nova Scotia, and I assumed I did my undergrad at Dalhousie, and I figured I'd stay there. And Dalhousie really produced family docs. That's what that place was about. But due to some life circumstances, I ended up deciding I wanted to leave Nova Scotia, and I went to McGill. And at the time, anyway, in the early 90s, McGill and U of T were the two places that really generated a lot more specialists out of their medical school class. I think it was just because of exposure. And I got turned on to surgery, and then I got turned on to heart surgery, and then I did a rotation. I really got turned on to heart surgery, and then I did a rotation in the States and another one in cardiac surgery that involved pediatrics, and it was a prominent place that was really involved in the foundation of pediatric heart transplantation, and that really just sort of highlighted it for me, and that's when I fell in love with all of that stuff and decided to be a heart surgeon. And kids made a lot of sense to me too, because again, not that there's anything wrong with taking care of adults, but it's a different kettle of fish. It's you're taking care of complete innocence, right? They didn't do anything. They didn't smoke their way into coronary disease. I'm not saying that everybody that's coronary disease caused it themselves, but you know what I mean. Kids are born with these problems, and there's something magical about just fixing stuff that they were born with.
Awesome. And did you work more so on like the congenital side of things, or?
Yeah, like I just did kids.
Okay. Wow. For us, like just coming into possibly starting med school soon, what sort of values or goals should we be coming in with, given that we are entering a system that we just spoke about has so many pitfalls?
Well, I think you have to dissociate yourself a little bit from systematic problems when you're talking about just going into medicine. Like, first of all, you go into medicine. I really think that people that go into medicine should go into medicine not because it's a job, but because it's a passion. I would never suggest that anybody go into medicine for just because it's a solid job or because there's money involved, because those two things don't really exist. But if it, and especially when it comes to surgery. So I mean, it's a passion to take care of people. It's a very gratifying position, and I mean, I gave this talk to my kids' grade 12 class, I don't know, 7 or 8 years ago, and I told them whatever job you do, like if you don't view it as a job at the end of the day, then you know you've made the right decision. Like you shouldn't have to force yourself to get out of bed. It should be something that you have fun doing and excites you. And so there's a lot of good things about medicine and a lot of excitement to be had. And I think you just go into it with an open mind. There's so many different aspects to it. You can choose so many different specialties or family medicine. And it's there's a lot of ways to be happy as an individual within it, despite the system not being perfect right now.
Awesome. Thanks so much for your time today, Dr. Gandhi. This has
Yeah, you're
been
welcome.
very,
Yeah.
very informative.
Yeah, take care.